So the whole question of mental illness and homelessness is a significant one. While the minority of the homeless population suffers from mental illness, there is nonetheless a significant overrepresentation of severe and chronic mental illness in the homeless population. In the general population, usually around 1% of the population has schizophrenia, and about 6% of the population suffers from a combination of the severe mental illnesses, most notably schizophrenia, bipolar disorder, and very severe depression. However, depending on the study and the estimate, you can say that anywhere from a fifth to a third of the homeless population suffers from severe chronic mental illnesses. And then either independent of or comorbid with major depressive disorder, bipolar disorder, and schizophrenia are the substance use disorders. Substance use is very overrepresented in the homeless population as well, both as a means of trying to deal with the other mental illnesses or as a disorder in and of itself. The majority always does not have mental illness, but there is such an overrepresentation of severe mental illness in the homeless population. This becomes even more profound in certain subpopulations, at least here in America. So if you look at those who are chronically homeless, because most homeless people are only homeless briefly. In general, 2 or 3 days might be a homeless experience. That's far more common than what we imagine of someone who's been on the streets for months to years. But when we think about those who are chronically homeless, or if we think about homeless women, they have an even greater overrepresentation of mental illness. So up to half of those populations are suffering from a chronic mental illness. The homeless that we see are more likely to suffer from a chronic mental illness than the greater homeless population, because those who don't suffer from those illnesses are going to be more adept at staying invisible. Some of them will continue to work, and they'll make better efforts to blend in, even though they are equally homeless. Schizophrenia is one of the most severe chronic mental illnesses. It accounts for about 1% of every population. Wherever you go in the world, whatever little segment you look at, about 1% always end up with this disorder. And it's probably better thought of as the schizophrenias, in that there's probably a host of different genetic and other insults that can conspire to create this condition. So not everyone, schizophrenia is a general term that probably accounts for multiple similar but slightly different illnesses at a genetic or molecular level. The hallmark of schizophrenia, though, is psychosis, which is a combination of hallucinations, of delusions or false beliefs, and impairment in thinking. So schizophrenia, at one level, is a disorder of sensory perception and of sensory gating. Sensory gating pertains to the way that we focus our attention on the senses that are the most important at the time and what's most relevant within that sense. For example, in theory, you might be concentrating more on my voice right now than the ambient noise that we might hear outside the building. However, with people with schizophrenia, sometimes there's an equal access to all sensory experiences. So there's a difficulty in the brain to target or focus on the most relevant sensory stimuli. So my voice in the conversation might have equal opportunity with the other ambient noises or other things that we hear around the building. That obviously is clouding and quite a challenge to navigate the world where all the sensory input may be getting equal time on stage. There's also an element where people with schizophrenia have sensory experiences, most commonly hearing voices, that there is no stimulus for. Now, these aren't like the voices that we hear inside our own heads when we're thinking through a problem or when we're reading, for example. We all hear some kind of voice, but it's very clear that it's inside our head, that we are generating it. In people with schizophrenia, the voice really sounds external to them. So it is not experienced as that internal monologue, and there isn't the sense that they have generated it. It feels like it's coming from the outside. And it's most common auditory hallucinations, their voices. Very often in the media or in film, it's difficult to depict that in a visual medium. So we often incorporate images when we depict someone who's suffering from schizophrenia, where we see a person that might be speaking to them. But that's not really the experience for most people with schizophrenia. It's possible, but fairly rare, that anyone sees anything. What they instead hear are voices that are with them wherever they go. And this obviously is quite disconcerting. The voices are typically multiple. They typically are of both genders. And they tend to not have anything very nice to say in general.
They're not supportive?
Not really. Actually, almost never are the voices supportive in schizophrenia. They're exclusively either derogatory, insulting the person, demeaning the person, perhaps undermining a nicer thing that another person just said about them. They can be command hallucinations, but again, they're never inspiring or good advice. So they never tell you to start an exercise program. The voices typically are destructive and telling people to either harm themselves, to harm other people. The last variety is really almost like a Greek chorus, just a maddeningly neutral narration of all of the events of the day as they're going on. So you would just imagine sitting there, going through your day or having this conversation, and this other external voice just narrating everything that's going on. This person is talking to you right now. It's daytime. I'm just sitting here. I'm not really doing anything. More just imagine just this neutral narration of all the events that are going on. You don't particularly need this information. You're already aware of them, but this voice just keeps narrating it. Those are the most common varieties of auditory hallucinations in schizophrenia. Any idea of a voice that's somehow helpful or giving advice or inspiring or helping you with your homework, those tend to not really fall into the category of schizophrenia. One exception might be when someone is in a different state called mania, that they occasionally may have auditory hallucinations that are very grandiose or somehow interpreted at least that way, that they feel celebratory and praising. But that's really rare. By and large, the voices of psychosis are either derogatory, commanding to do terrible things, or just neutrally narrating the day.
Is it a genetic disease?
It is. It's a genetic illness. Multiple genes must all align and conspire to afflict people with this condition, but it definitely has a strong genetic component that affects all sorts of the ways that our neurons communicate with each other, the way they develop and grow in the growing brain, and the connections that they make can all be perturbed in different ways. It is not dominant. So while individuals with schizophrenia have an increase of transmitting this disorder to their children, by and large, the majority of their children will be unaffected by the illness. Because it really can't be reduced down to just one or two genes. It requires multiple genes to all conspire to give the condition. So even two parents with schizophrenia will still have children that do not have schizophrenia, although they will certainly be loaded with genes that might otherwise predispose them to. But it is still fundamentally transmitted in it's not as simple as just dominance and recessive. but it's certainly not a dominant disorder. It's very rare for children to develop schizophrenia. It's a disorder that classically presents in the early 20s. In the very rare instance when schizophrenia occurs earlier in life than the early 20s, it's usually a situation where there is an exceptional genetic endowment for the disorder. But in its classic form, it really presents in the late teens, early 20s. One of the perfect times for schizophrenia to present is, at least here, is when people go off to college. This is very often a phenomenon in the first year or two of college. And there's a couple reasons for that. One is it's the developmental stage and the maturation of the brain at which the disease seems to really take hold. But another is that it's a sudden increase in stress. And certainly that can help precipitate the first manifestation of schizophrenia. So leaving the home, going away to college, all kinds of new stressors, being surrounded by strangers, everything is unfamiliar, and those forces can help bring out the first manifestation of the illness. That's not to say, obviously, that it's caused by this. It is going to manifest itself one way or the other, but that particular setting of going off to college seems to be really rife with risk of precipitating it right then. We talked about the sensory component of schizophrenia, the difficulty in gating different sensory input and of having experiences for which there's no stimulus. The other side is that schizophrenia is a disorder of thought. People can't think through situations as effectively. Everyone can understand at some level the idea of a hallucination. And certainly everyone can understand a delusion, that we simply believe something that isn't true. But the disorganization of thought that happens in schizophrenia, that's a little bit harder for people to understand who wouldn't have access to that experience. In some ways, you can understand it by thinking about language and the way you or I might answer a question. In general, with a normal thought process, you might ask me a question, and then I answer it. As my thought starts to become disorganized, some things start to change. So you might ask me a question, and I begin to answer it, but I seem to need to go through many steps to get to the answer. So I don't get right to it, but you can almost see my thought processes. I need to think about this to get to the next thought, to get to the next thought, to eventually get to your answer. I have kind of a circuitous route, a roundabout way of thinking through the answer, but I do get there eventually. As my thought becomes more disorganized, I might start on that route, but really veer off. And I never really get to answer your question. I'm talking, you understand me, my words are still organized, the structure of my sentences are organized, but they're not really pertaining to what you asked me. Then, as I become even more disorganized, there starts to be subtle disruptions in even the organization of my speech. My sentences now don't exactly make sense within them. So whereas first, you could understand what I was saying perfectly, but maybe we're struggling to figure out how this answers the question you asked me, now you're having a little trouble following, even within the structure of my sentences, what I'm talking about. And then at the greatest level of disorganization, we might have that even individual words, which an older term for this used to be called verbigeration, or we now call them neologisms, or new words, where even the individual words are mine and mine alone. They don't make any sense to you. And so this is a progression of my thoughts becoming more and more disorganized, from me first having to take kind of a roundabout way to answer your question, to next just kind of veering off, not really being able to answer your question, to further being disorganized even within the structures of my sentences, And finally, that even my individual words don't make sense. And then I suppose you can go one step further where I'm essentially mute or catatonic. When you interview someone with schizophrenia, part of how you assess how disorganized their thought is by paying careful attention to their use of language. Can they answer the question directly? Do they have to meander to find their way? Can they not answer the question? Can I not follow them? Or can I not even understand the words that they're saying? This is kind of the progression as people are more disorganized in thought. So that disorganization of thought is ultimately one of the most impairing parts of schizophrenia, because people can't think through problems when they're acutely psychotic. When they are particularly afflicted by the illness, they have trouble thinking. So we talked about how for people with schizophrenia, their thinking becomes disorganized. And a common reaction to that can be to develop a sense of paranoia, to know that something isn't right, but I'm not sure quite what it is, but I think someone's behind it or something is behind it. But then with this condition, it follows you everywhere. So if you're home, if you're on the street, if you're in a car, this sense that things aren't right, this difficulty you're having with thinking, and these occasional sensory experiences that shouldn't otherwise be. You can hear someone talking to you who isn't there. You have to start to think, who could possibly be behind this? How could this be happening? We all always tell a story to try to make sense of the world to ourselves. So in that paranoia, we often resort to things that could follow us everywhere. In older times, it would have been far more common to think this is the work of God or this is the work of the devil. Certainly either of them could see me wherever I am, talk to me wherever I am, know what I'm up to. But as we travel into modernity through time, there have become alternatives, whether government organizations, the CIA, the FBI, and their use of technology. There might be microchips or drones or whatever it is, somewhat based in reality, but what could possibly know where I am all the time, be following me all the time? And that's why these delusions often become of these very powerful entities that must be after people, because who else could keep up with them? Now, that's not universal. Sometimes people can develop a paranoid delusion around people that they know very well, and they might fill in some of the gaps with the use of technology or something like that. Their apartment's bugged, things like that. Or, as thoughts become more and more disorganized, there may be no need to account for the discrepancy in what it is that you think is going on and whether or not it could be possible. So another element that's worth knowing of schizophrenia is that it's a dementing illness. Actually, the original term was dementia precox, meaning precocious dementia. It was trying to find a way to identify these young men predominantly that seemed already demented, even though they might only be in their 30s or 40s. The reason for this is because psychosis itself is unhealthy for the brain. If someone is psychotic and that is not treated, it results in damage to the brain. The neurons involved ultimately suffer from something called excitotoxicity. As they are overactive and overexcited, this leads to an influx of calcium into the cell. And as that calcium accumulates, it can trigger for that cell a process called apoptosis, which is programmed cell death. So the cells kill themselves ultimately. And this is an oversimplification, but that's part of the way that untreated psychosis is a dementing illness, and that ultimately we lose brain functioning that we won't get back if we don't treat this.
It's scary.
Yeah, it's not healthy for your brain to be psychotic. And while we certainly want to respect people's rights, and if they are not dangerous to themselves, they're not dangerous to other people, and they do not want to be treated, then we will not and should not force that treatment on them. However, there is damage being done by being chronically psychotic. There is cell death within the brain, and it's ultimately a dementing illness. Another way of talking about schizophrenia is talking about it in terms of positive symptoms and negative symptoms. The positive symptoms are what we all know about schizophrenia, the idea of hallucinations and delusions. The negative symptoms, I think people don't really appreciate in the same way, but they are this sort of apathetic force, this gradual diminishing of any impulse to care for yourself. So whereas we're constantly monitoring ourselves, if we're eating with someone and we feel like some food somehow fell and got on our shirt, we immediately become self-conscious of that. We want to address that in some way. We're really monitoring ourselves, and particularly as it pertains to these social interactions. The negative symptoms of schizophrenia are really a loss of that monitoring. And so things like keeping up with hygiene, or with how fastidious we might be otherwise, or things like eye contact. These are all the negative symptoms that gradually go away and are actually the far more impairing symptoms of schizophrenia. People have trouble working, have trouble making alliances with other people, have trouble navigating life more because of this negative symptomatology than of hallucinations and delusions. Certainly those are more dramatic and can in the moment be certainly a lot more exciting for other people to talk about. But people can learn to cope around hallucinations and even work within some delusions. What people can overcome are these negative symptoms, this inability to motivate, to really have much affect or emotional life or expression anymore. Those things are really what impair people with schizophrenia the most.
I don't understand what those two words imply, because positive and negative doesn't mean good and bad in this situation.
Yeah, I guess they are. The terms are, the positive symptoms are things that schizophrenia makes you do, and the negative symptoms are the things that it keeps you from doing. So they're the lack of something as opposed to the presence of something. We often talk about people with schizophrenia as having a blunted or flat affect. Most people with the illness over time will have less and less emotional expression in their face. And affect is how you see the emotion in someone else. So a blunted affect is someone who doesn't smile, who doesn't really emote in any way when they're talking, is fairly flat. Another feature with more advanced schizophrenia is the loss of prosody in their voice. So all of us have a natural kind of musicality to our voice. It's not a huge range, but we go up and down and fluctuations, and that prosody sometimes diminishes in people with schizophrenia, that they begin to sound more monotone and certainly without a whole lot of feeling.
Yeah, I do that. I never heard that. That's interesting. Yeah, now that I think about it, though.
Right? The little range of notes that we speak in.
The cadences.
Yeah, right, all the cadences, they diminish, and people start to talk more robotically sounding and just short. And that affective quality is what engages other people in your speech. Even now, if I was, well, even with some affect, I might be losing everybody, but even if, if I was to speak just monotone, almost imagine the worst teacher you had in school growing up, like the person who just had no feeling, no inflection, just like they're reading to you. It's hard to engage with that person. It's hard to care about what they're talking about. Well, this is one more disability with those, particularly with untreated schizophrenia, is that the way they speak it doesn't engage people. It's very hard for them to elicit cooperation from other people. We are social animals, and some of our greatest skills and most important skills and traits are the things about us that make other people want to help us. We can't navigate life simply by dominating other people or by just yielding to everyone and being dragged along. What we do for most of our interactions is we find ways to cooperate. And people with schizophrenia are impaired on so many counts in that basic ability to get people to want to help them. First is that people can't understand them. They may not understand the illness. There's certainly something wrong. There's something different that makes people uncomfortable, that makes them afraid. But then the language might be hard to follow. And then even the emotional tone of the language is so flat that we're not drawn in. I mean, if we think of a baby's speech that doesn't make any sense, but it has this wonderful musicality that, I don't know what you're talking about, but I definitely want to help you with whatever it is. Like, let me get excited about this. We have the other extreme, where we've not only lost a lot of the verbal skills, but we've lost all of the musicality, the prosody. And it's hard for someone with schizophrenia to communicate in a way to draw someone else in to help them. Then the person themselves might be quite afraid. They might be worried that the other person means them harm. Or they might be just so distracted by all of the sensory experiences that they can't filter. The voices that they're hearing, plus just all of the noise that is in the world. They can't prioritize as easily. That's called sensory gating, where you focus most intently on, for example, the sound that's most important. If someone's talking to you, you really focus on the speech and you try to ignore the background noise. But that gets disturbed in schizophrenia, where everything gets equal access. So the car honking and the person speaking are equally important, at least in that moment. So it's such an effort to think and to listen to someone because you're trying to sift through all of this extraneous information.
Sensory gating is something that healthy people do, and they have schizophrenics have the inability to do.
Exactly. Healthy people are typically very developed in their ability to do sensory gating, to prioritize the most important sound in the room. Those who are suffering from schizophrenia lack that ability to gate. The gate is open. All the input gets equal opportunity. So all of the sounds in the ambient environment, the person speaking to you, they all get equal attention. So you're struggling to focus on the right things to follow a conversation, for example. Aside from the things we've talked about with delusions and hallucinations and disorganization of thinking as problems for people with schizophrenia, there are some other things that are worth talking about that might be a little bit more subtle. And they are dealing with strangers, conforming to society, and also needing to be incredibly flexible to integrate with society. These things don't fall into the classic diagnostic criteria of schizophrenia, but they're really responsible for a lot of the impairment in people with this illness as they navigate the world. And interestingly, it leads to a situation where in some cases, this might be an illness that you can have a better prognosis in an underdeveloped country compared to an industrialized nation. The first is how it is to interact with strangers. In the industrialized world, let's take it to the extreme. In a city, you are bombarded by strange faces, strange people, for whom, under normal circumstances, you have no concern, really, with their identity, with their intentions. By and large, you're doing your thing, they're doing theirs. In many ways, there's no place to have more privacy or more anonymity than in the middle of Manhattan. Everyone's doing their own thing, and it really doesn't matter to you. But imagine if you have the mindset that is more paranoid, that's actually quite concerned or even convinced that there are forces conspiring against you. And now you're dealing with different faces, new faces all day long. Is this one of the people that might be part of this? Is this not? It's quite terrifying to have to interact with that many strangers. Now, that's not to say that people familiar to someone with schizophrenia are immune from being incorporated into these kinds of delusions. Very often people that someone knows will become part of it. But there is a certain ease with which someone with schizophrenia can navigate their day if more reliably they know almost all the people that they're going to see. Another thing worth considering is that we require tremendous flexibility in dealing with the cities. Think of all the different interactions that you can have in the course of a day in city life, from the bus driver to the person who gets your food to your co-workers to it's just ongoing and ongoing, that we have to be very flexible and we act differently in all of these different situations. We have a different approach to our co-workers than we do with the taxi driver, than we do with the person selling a pretzel. These are all very different, but they require a lot of flexibility that can be very challenging to people with schizophrenia, who are really mobilizing all their resources to think, to navigate the day. And this need to be flexible, that I have to be different with you than I am with you, because the context is different. This is a real challenge. You also need to be incredibly conforming to live in modern cities. So while you need a flexibility for all these different interactions, for each one, there is a whole host of unwritten rules of the way you have to behave that you have to keep track of. Most of us do it without even thinking. The way we keep our space in line, the way we walk on the sidewalk, all of these interactions, we are conforming to countless standards that we have learned. That conformity is also difficult to people with schizophrenia, particularly as the illness advances. So in some ways, the city becomes the worst possible environment for someone suffering with this illness. They are bombarded by strangers. They have a tremendous need to be both flexible and conforming through hundreds of interactions in just the course of one day. Contrast that with a village setting, even in an underdeveloped nation, but where your community usually ends up about 250 or so people, and that's who you're going to interact with. You're going to interact with them every day. They all know you. You know them. These things help the functioning of someone struggling with schizophrenia. And it's one of the rare instances where you might sometimes be better off having an illness in a place with far fewer resources than when you think of the resources that, in theory, the great American city should have. Now, there are other variables, of course. Access to medications and treatment. Stigma can be very different in different societies. So some with these oddities may be completely shunned or could be more embraced or seen as a side of the other side of a gift of some sort. There are all different cultural ways to interpret this phenomenon of schizophrenia. So certainly there are places where it can be devastating in any corner of the world.
But in general, you'd say the more population, the greater the population density, and the more complicated the environment, the more marginalized these people are in society.
Absolutely. The more strangers you're going to have to encounter, the more you're going to need to conform to different contexts all day long, and the more flexible you're going to need to be. All of these things which are pulled for by the modern industrial city, the worse your prognosis is going to be if you're struggling with schizophrenia. It's really an unbearable illness, untreated. Fortunately, there are treatments for schizophrenia, And many patients can do pretty well. But what they require is adherence to the medications, adherence to other psychosocial treatments. That can be very hard to do. People with schizophrenia often have, there's something that I don't know if it's as popular today, but it was always referred to as the downward drift theory. That an individual with schizophrenia just starts to drift downwards in society, that all forces are aligned to fall lower and lower. So that people are less likely to have income, they're less likely to have friends and other community contacts, they're less likely to have transportation. All these things, the poor get poorer. So even though there are treatments, how can they be accessed with no resources, with no transportation, with no people really willing to help you because they're either afraid of you or you've burnt those bridges. So it's very hard. It takes a lot to keep your social status with schizophrenia. Now, born into a circumstance where you have a community that understands the illness, that gets on it early, that helps you get the treatment, then you can work, you can have a family. I mean, all those things are still possible, except in the most severe manifestations of the illness. But you need a lot of things lined up to help you. There's no getting past that. The presence of severe mental illness, even more so, and it's compounded by substance use. These are the least among us. There is no demographic that is more stigmatized, that is more on the margin than those with mental illness. And whereas mental illness can often predispose to substance use, then that combination becomes sort of this supremely condemnable population whose behaviors might be frightening. And with that element of substance use, the liability is all transferred to the individual.
So what about the treatment program?
For schizophrenia?
Yeah. Why, first of all, why don't people stay with their program if it's working for them? Because that's something that's common, is they don't want to take drugs.
Sure. There is such stigma to taking the medications for mental illnesses that people want to be off them the day after they start them, even if they work. And even more so, when they work. People take these medications, they remit, their symptoms remit, they get better, they're functioning, and they think, I'm doing great. Why should I take this medication? The problem is you're so aware of it. So when people have hypertension, they felt fine. They didn't know they have hypertension. The doctor tells them they have hypertension. They say, this will hurt you. Take this medication, and this will protect you from that. They didn't feel bad before. They don't feel bad, hopefully, after, if they're not getting side effects. And people might adhere to that medicine a little bit longer term than they might with a psychiatric medication. Sometimes there could just be a misunderstanding in how these medications work. While there are medications that treat and contain schizophrenia, there are no treatments that cure it. So these medications, even if they optimize someone's functioning and thinking, they have to be taken for life. So far, we have not found any intervention that can be done one time or for one course, and that's it, you're done. So they have to be taken every day. And people actually have trouble adhering with almost any medication every day. I mean, if you just look at an antibiotic prescription in general, who finishes their course of antibiotics? All the strep throats and pneumonias and bronchitis. Well, when you look at people's bottles, they've always got pills left over. They feel better, they're not coughing anymore, their throat doesn't hurt, and they stop taking the medication. A lot of people don't particularly want to take medication. It's totally understandable. They know they should for whatever it is, but once they are subjectively feeling better, they stop. It's no different in schizophrenia. You're feeling better, you're functioning, things are going well, you stop the medication. Of course, what's dangerous is after a while, you'll do fine for quite some time having stopped the medication, but there'll be an insidious onset of the symptoms. They will return. and you may not notice. You still think you're doing fine, but your thoughts are getting just slightly disorganized. You're maybe getting a little bit paranoid, but nothing. I mean, people get paranoid. There's a whole bunch of healthy people will have conspiracy theories here and there, but it's subtle. And then, of course, as the illness progresses, another characteristic of schizophrenia is there typically is no insight into it. The person who has the illness doesn't really usually appreciate that they have an illness. They might in the early stages think something's wrong, there's something going on, but it's very hard to sometimes people believe the reality that they are experiencing as a result of their illness. This is, no, I don't need a pill. I need someone to protect me. I need to get away. You're just trying to control me. You're a part of the conspiracy. So there's these terrible tensions in treating people with more severe schizophrenia that makes them resistant to take medication.
So you're saying they think everybody has these thoughts in their heads? Like if you don't think there's anything wrong with you and you're having auditory hallucinations, you think everybody else is having them as well?
You just, again, because the thinking is impaired, you may not stop to think about that. So I'm not sure that it's justified by thinking, well, I'm hearing voices. I'm pretty sure everybody hears voices. No, because that requires this kind of objective, sort of logical way of thinking about this. I'm hearing voices. These voices are real. I'm living. I know what's true. I'm me. It's very hard to get someone to question their own sense of reality. And you wouldn't want to do that too often, right? I mean, we want to really be right if we are trying to suggest to someone that their reality is not true. It's an incredible responsibility and burden to decide for someone that your reality isn't true. In some ways, the severe illness is the easiest because we can all feel pretty comfortable saying that we're pretty sure. You know, the more preposterous the delusion might be, you feel a little bit more comfortable trying to guide someone away from it. But not all of it is always that profound. Sometimes it's more subtle. Sometimes, do we tell someone that they aren't on a particular mission for God? Maybe they are. I mean, we don't want to necessarily take or try to take that from somebody. But what emboldens us to do so are really the same things that embolden us in the treatment of all mental illness. They are suffering and impairment. If people seem to be suffering and can't do what even they say they want to do, that starts to feel like this should probably be in our realm and something that we should try to help with. But if people are not suffering and are not impaired, their thoughts are their own. I mean, who am I to say what is right, what is wrong, what your relationship to God might be, what the government's about? I mean, everyone's entitled to these things. But when there's impairment and there's suffering, and then the other factor that emboldens us to step in is when there's danger. In general, we tend to accept that if people are harming each other or harming themselves, there's something wrong, and that we should try to intervene. But it's an incredible responsibility to have to make this determination. I mean, I'm talking about the easy stuff. Someone's trying to kill someone from a whole out of a delusion, but there are far more subtle possible delusions, maybe not, that sometimes you have to make a judgment call about, and you try not to. You try to stay out of people's thoughts unless there's just something so clearly impairing them that is giving them suffering or that is endangering someone. In general, people with bipolar disorder often have a better prognosis than those with schizophrenia, largely because their illness is episodic. So for those afflicted with bipolar disorder, the majority of their life can be spent what we call euthymic, or in a normal mood. Normal adult mood is neutral. A good thing happens, we get happy for a while, and then we drift back to neutral. Something bad happens, we might get sad, we drift back to neutral. That's euthymic. But in bipolar disorder, episodically, people go into different mood states. Either depression, which is characterized by sadness, withdrawal, inhibition, inability to sleep or eat or concentrate, thoughts of killing yourself. Or contrast with that in alternative mood state, which is mania, which is typically characterized by increased energy and no need to eat, no need to sleep, because you are so full of energy and enthusiasm, and it can be very euphoric and feeling on top of the world, or it can be highly irritable and just incredibly angry. And I describe mania as an alternative as opposed to an opposite of depression, because it really isn't the opposite of depression. It seems from the outside, well, this person's really, really happy and this person's really sad. But these are two different reactions to the same kinds of life stressors. So when we talk to someone who's depressed, if there's a story, many people can be depressed without any instigating event in life just because they are vulnerable to that disorder. But if there is a story, it's usually one of futility, of failure, of bad things happening. When we talk to someone who became manic, we don't get a story of great things happening. No one says, oh, I won the lottery and then I got a promotion at work and before I knew it I was manic. Actually, their story is usually the same as the depressed story. I may have lost someone close to me, I lost my job, broke up with my significant other, bad things happen. And in people with this genetic predisposition, they go into an alternative mood state from depression, which is mania. Mania is the alternative mood state to depression that either spontaneously or after, as a result of adversity and failure and futility, you enter this mood state, which is, on the outside, seems opposite to depression, but it's just a different way of reacting. The mood is either euphoric or highly, highly irritable. People typically don't need to sleep because they have so much energy, so it's not unheard of for going days to a week with no sleep at all. But unlike a depressed person who might be craving sleep but just incapable of achieving it, the manic person doesn't particularly need to sleep. Their speech is typically very fast, their thoughts are fast. They can sometimes be marked by periods of creativity and productivity, but ultimately it's self-defeating and non-productive. Subjectively, the person who is manic might think they're doing their best work ever, whether it be artistic or whatever their field is. But usually to the outside or to the critic, this ends up not really their best work. They're ultimately quite impaired. Mania is often associated with psychosis, like schizophrenia, where voices are prominent, hallucinations, delusions. In mania, those delusions are more commonly of a religious nature. So hyper-religiosity sometimes characterizes mania. Of course, this relies on you knowing how religious someone is when they're not manic. Some people are just very religious, but it's more common that the person who is, we'll say, of average religiosity in their periods of mania becomes extremely religious. And then often the behaviors, because of the impairment in thought and the psychosis, really can often be quite contrary to what the actual religion might ask of that person. But it's much more common to have sense of God being behind you and of these great, of this incredible religious significance to what's going on. People manic also can become very hypersexual and behave in ways that are completely uncharacteristic of them when they're euthymic. I mean, being promiscuous and doing all sorts of things that are just not who they are in their normal mood state. People with bipolar disorder are often at risk of losing their jobs. They often overspend in a manic state, so they may blow through all of their finances. They may just make the most terrible financial decisions in that state because they're really calculating the odds wrong in this euphoria. They can gamble, they can buy beyond their means, and it can really have devastating consequences. People lose their homes, families are destroyed, sometimes by a manic episode. Even though treated or not in that state, these are not the behaviors this person would have ever done. So bipolar disorder is another severe chronic mental illness that contributes to the homeless population, similar to schizophrenia. It is also treatable, and people can be maintained with a normal mood state on medications and with therapy and other interventions to live completely normal lives. Neither of these things necessarily should condemn you to this life of homelessness and of such impairment, but certainly the avoidance of treatment, letting the illness take its natural course, doesn't work well for the individuals.
Is it the same with population density and things of that sort? Would a smaller region accept a bipolar somebody suffering from bipolar disorder more than a more urban population?
I'm not aware of that exact kind of study being done looking at bipolar disorder in particular. Bipolar disorder is very dramatic, though. True mania, by definition, deviates so grossly from societal norms that in many ways it is more intrusive, it's more interrupting than schizophrenia might be at times. It's by definition, the mood is so elevated that people are impaired and are having bad outcomes. So unchecked mania in the American city very often ends in hospitalization or an arrest. These behaviors are pretty out of control.
Why hospitalization?
Because to some extent, that's at the discretion usually of the police or the person who encounter the patient. So someone's behaving in a completely inappropriate way. That decision of whether you go to jail or to the psychiatric hospital is a little bit made on the spot sometimes. However, I think law enforcement professionals are quite adept in general at realizing that this is criminal behavior, but coming back to jail with us is not what this person needs. And they will typically divert these people to the emergency room where we see them and then hospitalize them. People who are manic are very dangerous to themselves. They can just devastate their own lives. But the challenge is they subjectively have never felt better. They are feeling great, powerful, fast, smart, attractive, everything, and completely lacking insight into the trail of devastation that they're leaving in their wake. Now, these are the extremes. People can also achieve lower states, sometimes we call hypomania, which is, again, an abnormal elevation of mood, but doesn't quite reach the extremes of mania. But bipolar disorder is another disorder that is overrepresented in the homeless population. At its worst, it can be as psychotic as those with schizophrenia. The difference between bipolar disorder and schizophrenia, in part, is the episodic nature of bipolar disorder. People restore to a very normal baseline and have episodes during which they are manic or they are depressed. People with schizophrenia typically have at least the potential for the illness all the time. Although if it's being treated, then those symptoms are in remission. However, people with bipolar disorder will have many periods of their life, even without treatment, that they're doing fine. The importance of treatment is to prevent the potential of going into those states. And that seems to require, at this stage, it seems to absolutely require medication. Manic and depressive episodes can arise seemingly spontaneously, or they can both be precipitated by stressful, upsetting life events. What doesn't happen is good events in life don't precipitate either. No one has had such a great month that they find themselves depressed, nor do they have such a great month that they find themselves manic. These are two options. If they're reacting to anything, they're reacting to stressors in life, but they can both happen spontaneously. A third illness that has some overrepresentation in the homeless population is major depressive disorder. While this is far more common than bipolar disorder or schizophrenia, it probably is less represented in the homeless population compared to bipolar disorder and schizophrenia. Major depressive disorder is the vulnerability to either spontaneously or in reaction to events in life go into a major depressive episode. A major depressive episode is characterized by usually a decreased ability to sleep, a lack of appetite, an inability to concentrate, an inability to muster really any energy, a predominance of morbid thoughts, thoughts of killing yourself, and even attempts to kill yourself. This is a very impairing illness and fairly common, certainly compared to the other two of schizophrenia and bipolar disorder. When depression is severe, people can similarly lose employment, lose important relationships. The natural course of a major depressive episode is often around 6 months, although they can recur quite rapidly and people can stay depressed for extended periods of time. With respect to homelessness and substance use disorders, it's very hard to treat the homeless substance using population. There can often be this tension of whether treatment first or housing first makes the most sense for substance use disorders. An older mentality was treatment first. You get yourself sober and then we'll get you housing. But until you achieve that, there's no housing. But that probably isn't the best approach. And people have looked at whether achieving housing first diminishes success rate in substance use rehabilitation, and it doesn't seem to. So people who have a substance use disorder who then are given housing aren't less likely to recover than those who are still homeless. The idea that housing would be the sufficient carrot to overcome such a disabling disorder has been fairly disproven. So it doesn't look like we risk much by giving housing to the substance-using homeless person. We probably don't risk demotivating them towards rehabilitation because they have a safe place to live. Mm-hmm. So it's important to remember that while substance use and mental illness is overrepresented in the homeless population compared to the general population, it's the minority of the homeless population nonetheless. It's also a population that is so hard to treat. Here we have people with the most severe manifestations of mental illness and addiction, but it's very hard to treat people that don't have an address, that don't have means to get medications, to come to their appointments. It's just an unbelievable challenge.